For those of you who haven't met me, my name's Alan Yates. I'm the chair of the Cheshire and Merseyside Health and Care Partnership. And first of all, welcome. I think it's fantastic. I think we're still admitting people, so apologies for that, but we'll admit people. And if you're on late, you'll only be missing this boring bit of my introduction. So that's okay. You won't miss Roger, I think. Delighted that Roger's joined us to have this, first of all, presentation and then the opportunity to have a discussion. I'll introduce Roger in a moment, but thank you very much indeed for joining us. Really appreciate it, Roger. If I could just do the standard, please turn your microphone off if you're not speaking. One of the things maybe slowing us down in terms of people coming onto the call is they have to consent to the meeting being recorded. That's one of the reasons we want you to turn your microphones off, but also want you to be aware that it's recorded. You know, we had a session on Tuesday, perhaps, which was an excellent session, and quite a few people have asked for the recording afterwards, and that may well be the case. So it'll be good if we've got a good recording. Roger's going to speak for about 20-25 minutes and give us some insights to his work, I hope, and some thoughts that might be provocative for us. The idea is there's a question and answer session, which I hope might turn into a discussion as well, and it's my job to try and help that to work, so I will do my best. If you could use the chat box at the side, so allow Roger just to give his address at the start, and then we can. But if there's a question that occurs to you whilst Roger's speaking, by all means write it down in the chat box, and then we'll have captured it, and I'll try and then introduce you to ask that question. So if that's all right administratively, I'd just like to say hello again to Roger. We know quite a lot of things about healthcare and Black, Asian, minority ethnic issues now. And one of the things we know is not only that inappropriate discrimination is wrong, but that a diverse workforce has benefits and is linked to better care. So this is very important from all sorts of aspects for us. 6 years ago, Roger wrote his writing about the snowy white peaks of the NHS, highlighting the scale of race discrimination in the NHS, and the UK's biggest employer of Black, Asian and minority ethnic staff is the NHS. And that was all before COVID-19 and what we've learned further about that. So the idea of this webinar is to start the partnerships conversation and examine the nature and impact of structural discrimination, inequality, and provide suggestions for integrated care system leaders in a way that ensures faster progress to tackle workforce race discrimination. So this is, I wanted to say, really important for us. It's a core theme for us. We are absolutely committed to tackling this issue. And that's what makes it great that Roger's found some time to join us today. You'll know, those of you who were on the place and programme meeting earlier, that we've tagged this along because, again, it's a central part of what we're about. Roger's a research fellow at Middlesex University Business School. As I said earlier, authored guidance on race equality in the NHS, including discrimination by appointment in 2013, the snowy white peaks of the NHS, which I guess just about everybody's heard of, in 2014, and designed the Workforce Race Equality Standard, and was then appointed National Director to oversee that between 2015 and 17. Roger's helped develop innovative approaches to help reduce disproportionate disciplinary action against BME NHS staff and disproportionate fitness to practice referrals. And he was Joint Inclusion Advisor to the NHS Talent Management Programme for aspiring directors. And Roger will have seen from his writing, but also we may have seen him writing in Health Service Journal, Nursing Times, Nursing Standard, British Medical Journal, The Guardian, The Independent, and almost the world. So delighted to have a speaker with such insight and background in this subject area. And Roger, welcome again. Thank you for joining us. We really look forward to what you've got to say to us.
Thank you very much, Alan, and good morning, everybody. I'm going to talk about the challenges that we face in equality, particularly race equality, and then suggest how we can do better. I'm going to speak, as Alan said, for a little bit over 20 minutes. And I'm going to, although some of what I'm going to say is drawn specifically from healthcare, wherever possible, I'm going to reference it across to the voluntary sector and local government. So you'll be familiar with the headline data on equality. And although this data is drawn from the NHS, available data suggests similar patterns in other parts of the public and voluntary sector. There has been improvement on some metrics, but especially on career progression and promotion, which I'll particularly focus on today, if I may. It's simply too slow. Just look at some of the numbers. So bias in recruitment, we have a seniority gradient linked to ethnicity, to gender, and to disability, with differential success at interview and access to career development, disproportionate disciplinary action and referrals to regulators and overseas staff, and with overseas staff particularly vulnerable. Actually, Alan, I should have said, was it possible to put the slides up now? I forgot to say, if you don't mind. Thank you. That's my mistake, apologies. The staff survey item that most consistently strongly linked to patient survey scores is discrimination. Next slide, please. In particular, discrimination on the basis of ethnic background. We know that bullying, harassment, and incivility disproportionately impact on LGBT, disabled, and BME staff. And we know that the percentage of NHS staff reporting that their trust provides equal opportunities for career progression is related closely to CQC ratings of quality of care, use of resources, and levels of staff absenteeism. And I think it's fair to say, because I've done some work for Skills for Care, and indeed Skills for Care with the Department of Health are just about to launch a pilot of the RES in social care. These sort of data applies across and outside the NHS. Next slide, please. Why does it matter? I think you know this, but just as a quick reminder, it's about social justice. It's embedded in the values of local government, social care, and the NHS institution. It wastes talent, because if we're choosing people on the basis of ethnicity, gender, or disability rather than ability, that will affect what patients get and the morale and retention of existing staff who are not fairly treated. We know from James Nasru in Manchester that discrimination impacts on health, staff, and well-being. We know about bullying and its impacts on engagement, retention, performance, and team effectiveness. And we know that this is about improvement, not just about compliance. And there's a wealth of evidence showing the links between how staff are treated and the care provided, retention rates, and so on. And I put some references all the way through these slides if colleagues want to follow them up. So the case for discrimination is a powerful one. You, I think, understand it in general, but I think it's really important that everyone is confident about making the case. So next slide, please. The issue of race in particular is important, even in areas of the country like yourselves, where the proportion of BME people in the population and BME staff in the NHS is relatively small, partly because the behaviours and denial of careers opportunities for any group are a waste of talent, partly because the number of BME staff is going to increase significantly in the NHS, particularly in NHS, but also elsewhere. And partly because we find it harder to talk about race than almost any other issue we need to pay special attention to. And you may want to return to that in discussion. Next slide, please. Sorry, keep that one, sorry. COVID-19, yeah. So very briefly, COVID-19 underlined the importance of race equality. Almost 9/10 of staff infection, according to Public Health England, was due to occupational exposure. BME staff were disproportionately impacted, as you know, and I don't know what the equivalent figures for social care are in terms of BME staff, but I think we can assume that the pattern was not dissimilar. Key drivers of risk: BME staff were disproportionately in lower graded patient-facing roles, very rarely in leadership. Appropriate PPE and fit was less available to BME nurses and doctors, and was certainly less available overall for social care staff. BME staff, some certainly were reluctant to raise concerns, either because they didn't think they'd be heard or feared the consequences of doing so, something Robert Francis referred to in 2015. BME staff in some trusts were disproportionately redeployed to riskier areas, and there was a whole area with agency staff, which I won't go into the detail of, but where it was very clear that there were issues around BME staff. So a number of those are a legacy of patterns of workplace discrimination. Next slide, please. So if this is important, and I think there's a general understanding in the NHS that this is an important issue, that there are consequences for patient care, organisational effectiveness, and so on, how do we translate the speeches into practical action? And why hasn't that happened so far? When he did his public inquiry report on Staffordshire, Robert Francis said, and I quote, "There lurks within the system an institutional instinct which under pressure will prefer concealment, formulate responses and the avoidance of public criticism. A culture which ascribes more weight to positive information about the service than to information capable of implying cause for concern." And we've all been in organisations where there's a tendency to try and push positive information upwards. And I think there's a sense that that's sometimes happened on race discrimination. And secondly, protective hesitancy, which I think we're all familiar with, is something that results in some managers being reluctant to have honest conversations with BME staff when critical issues arise. And BME staff in turn not feeling it's safe to say what they really want to think. It's a kind of conversation on eggshells, becomes a conversational car crash. So that's two of the reasons, but there's a bigger reason, I think, which if we could look at the next slide, please, is the HR paradigm that I think people are finally reflecting on, and which has dominated not just the NHS and social care and local government, but generally across industry. It assumed that policies, procedures and training were the key to changing culture and outcomes. But research for some years has been clear that relying on them in isolation and on individuals raising concerns, which is what we've tended to do, is simply not enough. As an ACAS iterative review on bullying, for example, concluded that while policies and training are doubtless essential components of effective strategies for addressing bullying in the workplace, there are significant obstacles to resolution at every stage of the process, and research has generated no evidence that in isolation this can work to reduce the overall incidence of bullying in Britain's workplaces, and that is equally true. There's a whole literature around it in terms of recruitment, whistleblowing, and so on. A landmark review in the States of diversity initiatives concluded, and this may surprise some of you, that, quote, attempts to reduce managerial bias through diversity training and diversity evaluations were the least effective methods of increasing the proportion of women in management. And they found similarly, to a slightly lesser degree, that was true for BME staff. And the Equality and Human Rights Commission literature review by my colleague Doyen Atuolagun concluded similarly that whilst diversity training could improve cognitive understanding, there was minimal evidence of it changing decision making. Next slide, please. And that leads us into really the impact of bias, because if bias is really important in decision making, which it is in all sorts of ways, it's deep rooted, we need to think through what other tactics might work, what other strategies might work. And just to summarize some of the ways in which bias impacts. If you have too many, in quotation marks, essential criteria, it won't put off men, because we men are quite happy to apply for jobs that we can't do sometimes. Women are much less willing to apply for jobs that they can't do in their entirety. How jobs are advertised affects who applies for them. Informal and unstructured shortlisting and interview processes are really prone to bias. There's an excellent HEE review on that. And frankly, informal interviewing processes are not much better than sticking a tail on a donkey. The tap on the shoulder, which is very prevalent in stretch opportunities, which are really key to career progression, is equally prone to bias without people realizing it. Selection tests run the risk of measuring past opportunities to learn, not future potential. And affinity bias leads us to select people like us or who we think will fit in. It's worth noting, for example, that Google exclude future line managers from the final selection decisions on interviews. And finally, selection decisions may well be made in the first 4 minutes of an interview, which could lead candidates, does leave candidates from some backgrounds spending much of the interview clawing back adverse bias based on their protected characteristics, their ethnicity, gender, or disability. And finally, some panels easily confuse confidence and competence to the disadvantage of some people. So there's an alternative paradigm. If we could have the next slide, please. Which, for example, I did a webinar yesterday with NHS England. I'm delighted to say they seem to have adopted. I'm doing work with the Southeast region of NHS England, working with ICSs, the 6 ICSs in the region, and we've started to sort of start a discussion around these themes. And there are 3 or 4 key things that work better. The research is pretty clear. First of all, rather than relying upon individuals to raise concerns, triangulate the information we have and be proactive and preventative. Secondly, emphasize debiasing processes, not people. That doesn't mean that training should be abandoned, but it does mean that since we know it's not as effective as we think, we need to think of other ways. And I often give an example, which 1 or 2 of you may know. It's an example from 60 years ago. American orchestras were full of people like me, old white men. There was intense discussion and hand-wringing about how to change this, but nothing happened. And then one panel decided it would insert a screen between the auditionists and the panel so they couldn't see them. Hey presto, an awful lot more women were selected. Then somebody else suggested that candidates should take their shoes off as they walked to the place where they played. So you couldn't hear the clippity-clop of people walking to the stool that they would sit on. That further increased the number of women who were appointed. And I use that as an example that after many years of pressure that achieved nothing, simple change of process brought about a difference. As I referred earlier to Google, they decided the best way to deal with managerial bias was that the line manager wouldn't be part of the final selection decision. And that appears to have worked too. The next key intervention is inserting accountability. And that doesn't mean beating people up, but it does mean thinking carefully about how we hold colleagues to account. We know that panels whose decisions are scrutinized change their behavior. And again, another example from this time from the American Army, American Divisional Army HR Director. And this is a policy that's now been adopted in a number of NHS trusts in England, told panels it was not his job to tell them who to select. But if they didn't choose a shortlisted female or black lieutenant colonel for promotion, they had to write him a short note explaining why. He was astonished. It completely changed the outcomes of the interviews by forcing people to think carefully about why they were making their decisions and justify them. It's very common in the private sector, particularly in the City of London, that organizations hold departments heads to account for patterns of discrimination through what they call an explain or comply approach, building into KPIs a requirement to change. And again, that doesn't mean beating up managers. It means working with them to change those patterns. And it seems to work. And I'll put 1 or 2 other things there, which I won't spend time on: positive action, stretch opportunities, the importance of measurable goals, not because goals and targets in themselves change anything, they don't, but because what gets measured gets done, and it focuses people's attention. And finally, which I will now move on to discussing, is the importance of inclusion after appointment. Because without inclusion, research says that improved representation will not be sustainable, nor will it reap the benefits that it could and should do. Next slide, please. One or two of you may be familiar with Google's Project Aristotle study. It was looking for what were the most significant success factors underpinning their high performance teams. And this is what they found. Firstly, that the capabilities of individual team members mattered less for team performance than group processes, sharing information, collaboration. Secondly, when members of the team attached a low interpersonal risk to voicing their ideas or making mistakes, they felt safe. They were more likely to share novel information or challenge the status quo. In turn, the group was able to access and integrate a greater diversity of thought to drive innovation, improve judgment and decision making. And thirdly, employees in psychologically safe teams were also less likely to leave, brought in more revenue, and were rated as effective twice as often by their executives. So inclusion and psychological safety are really crucial, and I don't think we always pay enough attention to those. I've just put up there with the definition of inclusion as the extent to which staff believe they're a valued member of the work group, receive fair and equitable treatment, and believe they're encouraged to contribute to the effectiveness of that group. They can bring themselves to work. And her research showed that inclusive organizations are more likely to be psychologically safe because staff feel confident expressing their true selves, raising concerns, admitting mistakes without fear of being unfairly judged. And I know within your region, because I'm fairly familiar with it, the Working Mersey Care Trust has applied some of those principles around discipline, bullying, and patient safety, I think with some very considerable success. Could we have the next slide, please? So what are the benefits of diversity? I touched on the reasons why we needed it, but there's a wealth of evidence, and I'll just run through this very quickly. Creativity improves, innovation is more likely. There's more careful information processing. Women in particular in leadership moderate extreme behavior and improve risk awareness, more higher productivity, greater profitability, lower turnover. And as Eden King found, if organizational leadership better represents staff ethnicity, there is more trust, stronger perceptions of fairness, and overall better morale of staff. So finally, what are the implications for leaders? Next slide, please. We know from research that when the individual inclusive leaderships are characterized by challenging the status quo, making diversity and inclusion a personal priority, and not leaving it to those subjected to poor behaviors to challenge them. Leaders who demonstrate a high commitment to high quality and compassionate care directly affect clinical effectiveness, patient safety, the health, well-being and engagement of staff, and the extent of innovation. Extent of the links between psychological safety, supportiveness, positivity, empathy, leadership and innovation is deep and convincing, Michael West found. And finally, and I think this is really important, relational intelligence can be just as important as rational intelligence in building effective teams. What leaders do makes a decisive difference to whether improved representation turns into more effective organizations. So I want to conclude, next slide, with some takeaways, some suggestions. Firstly, no one should be a member of any board, I don't think, if they can't confidently explain to staff and managers and interview panels why tackling race discrimination is important for public services and demonstrate what they're personally doing to achieve this. We need to seek out and understand hard and soft data informed by curiosity, not by comfort seeking. We should triangulate such intelligence to be proactive and preventative, not relying on individuals. We should stop signing off action plans unless those proposing them can demonstrate why they are likely to work. That's the principle we would apply to a clinician putting forward a proposal. We should do the same around human resource issues. We must embed accountability in the ways that I've described, including for access to stretch opportunities, holding individual panel chairs and divisional leaders to account. We should think carefully about how we can emphasize debiasing processes, not just training individual managers. And that does mean granular attention to bias and how to mitigate it. We should prioritize psychological safety so that teams and boards become inclusive and leaders are better able to model the behaviors they expect of others. And finally, all this stuff is a driver of service improvement, not just a matter of compliance. I think they're essential for the sake of both patients, service users and staff. And hopefully there's something that can prompt some discussion within your own STP and ICS. Thank you very much.
Thank you very much indeed, Roger, for a lot of thought-provoking content there, and in a very concentrated fashion, which was extraordinarily efficient as well as effective. So thank you for that. The notion is, first of all, we have an opportunity to ask Roger any questions on the basis of what he said, but actually evolve this hour into more of a conversation about what can we as a community do, what do we want to commit to do to make a difference to inclusion, inequalities and diversity. So we've got a few questions from, sorry, because you're identified by sometimes a strange name, SMR Cunliffe. I'm going to suggest we ask those questions personally so that we bring them to life a little bit. So SMR Cunliffe, if you could switch your microphone on and ask that question and add any additional content to it that you wish.
I can see the question, Alan. If you want, I'm happy to answer it. If there's an issue.
Oh no.
Hi. Hello.
Just
Can you hear me?
Only just. You're very quiet.
Is that any better?
Yeah, we can hear you. Thank you.
It's really just about wanting to know what we can do to get more action, Roger, because having worked in a number of trusts, it seems to me that people say good things, but then the action that's needed to implement change doesn't happen and the evaluation doesn't happen. So my question was really about whether making res and res results a more important part of CQC inspection might add some emphasis to that.
Okay, so I struggle to hear slightly, so I'm going to base it, if that's okay, on your chat box, Crystal, which I think was pretty much the same. So at the moment, the res is in the health service is mandated for healthcare providers, including private sector providers, and it was one of the key lines of inquiry for the CQC in its inspection process. I think there's a view, which is also held by the CQC, that hasn't been as effective as it should be. Although I have to say, my own sense is that the fact that it's in the CQC inspection in itself has helped to concentrate minds, and certainly it's resulted in boards discussing issues of race discrimination on a scale that was certainly not the case before 2015. I think there's a limit to how much you can mandate. I think mandation is important. I think inspection is important, but I think it's really important that we pay more attention to helping organizations understand the sorts of things that work. And I don't think we've done that sufficiently up to now. And I think that the sort of presentation I've given today, which draws on the research about what is most likely to work, I think that's likely to make a much bigger change. It's interesting. The one metric that has changed significantly is the one around disciplinary action. The gap between white and BME staff being disciplined has significantly reduced in the last 4 years. And that's because there has been a type of intervention, different forms of it, which intervenes at the very beginning, at the point of incident, before there's any investigation even. And it says to managers, why is it necessary to carry out a formal investigation here? And the mere insertion of a behavioural nudge of accountability at that stage has substantially reduced the likelihood of disciplinary action. I think we need more of the application of the sort of principle I talked about to career progression and promotion, and I think we can have some confidence that will make a difference. We haven't been doing that on the whole up to now.
Thank you for that question, and thank you, Roger, for that response. I'm going to suggest we deal with questions, and then there are some other comments made in the chat line that sort of contribute to the debate rather than our questions. Dave Sweeney, can I raise kindness again? Dave, do you want to come on and just say something about
that? It's really, really, really interesting, Roger. Thank you very much. My cogs are blustering away here as you speak. There's a lot of like legislative stuff that you've commented on that we can make a difference. I'd just like to touch on the kind of human aspects within that. And when you put up kindness, I've been in the zone of health inequalities and social prescribing and people just being kind of nice to each other for a long time. And I've seen some really, really brilliant leaders who have that attribute. But we do see unkindness. We do still see people being singled out and shafted and stabbed in the back and all those kind of different things. And I just wondered if you could just kind of extend that conversation about how important from a leadership quality being kind to other human beings is. So for me, it's an imperative in terms of that leadership quality. But I'd just like to hear your thoughts on that.
Well, I think that's a lovely question, and I do presentations linked to it because I agree with you. We didn't have a few years ago, but we do now have a raft of evidence that how leaders behave fundamentally changes the culture of the organization. What leaders do or don't do makes a huge difference. Leaders that try to put themselves in the shoes of others, that see their job as enabling others, that pick up really quickly on rudeness. We often, in some organizations, I've worked in some, we get so used to people being rude, we don't realize that that is very close to bullying. And there's now lots of evidence that incivility, which has become the kind of technical phrase for unkindness, has radical impacts on people's performance, the effectiveness of teams. People disengage, they vote with their feet. That the impact of incivility is almost as great as the impact of the more formal, more recognized forms of bullying. And it really, it's the application of the old principle of treat others as you'd like to be treated yourself. And you can spot the good leaders. I've been in organizations where you walk around with the chief exec and you can he or she knows everyone. They all know. He will ask or she will ask, how is your child getting on at school? How is your mum in the care home? In big organizations I'm talking about, they know his first or her first name. And one of the interesting things that's happened in the NHS, just to sort of finish in a response, is that there's now an acceptance that compassion and inclusion should be a core competency in aspiring directors in the NHS. I was involved for a couple of years in helping to design that. Interestingly, we had quite an argument about why it should be included, but it is, because I don't think you can be a good leader if you're not inclusive and compassionate. You don't listen with attention. So I do think that's something we need to pay much more attention to. We can't expect staff to behave kindly to patients if we don't ask staff to behave kindly to each other.
All I can say is here. Jill and Lorraine both said something about psychological safety. Jill, would you like to come on, and then Lorraine follow straight on afterwards about your question and your comments?
Hi, thanks, Alan, and thanks so much, Roger. Really interesting conversation and such a crucial topic. And my question, I don't know that it's an easy question, is how we really get issues like psychological safety on the table as a really key enabler of this and this important stream of work. Because I think as an OD person, I've been talking about psychological safety for my whole career. And there are times where I think people acknowledge how important psychological safety is. But one of the overwhelming things that we find is that unfortunately people are reluctant to be as honest and vulnerable as we need to be to really get into that kind of conversation and make that kind of shift. And I'm just wondering, you know, how from your perspective, how do we do that? Because the evidence base is there, like so many of these things, but that kind of ability to really get people in that space to make the real shift. I just wonder what your thoughts are on that. Thank you.
If I can hold you there for a minute, Roger, and ask Lorraine to make her contribution as well.
Hi, thanks, Roger. That was a really great presentation, and Jill's just pretty much summarised it completely. My point. I mean, we've been having a lot of discussions recently about. I'm a Freedom to Speak Up Guardian. I'm the Speak Up Guardian at Liverpool University Hospitals, and we've recently made me full time so that partly we can get into a lot more of the proactive approach to raising concerns, listening to concerns. And it's not just for me about listening intentionally, it's also about seeking openly and proactively that information. And to do that, leaders have got to feel psychologically safe and feel that they have the support from their managers when they're trying to deal with difficult news and difficult information. Them in themselves feeling psychologically safe, then do you have any comments about how that influences the psychological safety culture of those that we're asking to speak up in the first place?
I have to say, Alan, these are brilliant questions. I mean, they go right to the heart of where the NHS needs to put its attention, in my view. So if you're a chief executive in the NHS, for many years, it was a very top-down system. If there was a significant problem in your trust, you could expect to get a Monday morning phone call, which you would then have to share with your executive team and then cascade down that, hey, we've got to sort out our waiting list because the minister's going to phone me next Sunday. I'm exaggerating slightly, but that is often what happened. So it was inevitable that sort of stuff cascaded through the organization. I think it's only really the last 4 or 5 years, if that, and probably Michael West has been the most influential person in creating an alternative narrative and saying that is not an effective way of working. And I think, so part of it depends on the leadership at national level of the NHS getting away from the command and control approach that I'm afraid comes very easily to people. I've said this to themselves directly. So, you know, I think that's really important. I think there is some evidence that some of that is changing. I see more chief executives willing to either stand up to what comes down or willing to sort of park it. So the expectations are, so first thing is the expectations nationally make a difference, but without putting all the weight on the leadership team in an organization, it is the way that the leadership team behaves that's probably what is the most important thing in terms of creating that space. Amy Edmondson, and you'll have read her stuff, talks about how leaders that demonstrate humility, who say that they're not sure, who admit mistakes, say that they are sometimes wrong, make much more difference to the way people behave than other leaders. So I think there's two things. The narrative is still not well enough known. It may be well known amongst OD colleagues. I don't think it's well enough known generally in the NHS. I think we are getting there. The fact that we have compassion now as a key competency for interviews, I think helps. But I think so the narrative has to be better. and we have to encourage and support leaders, not just the top leaders, but freedom to speak up guardians, for example, to give people the space and make sure that there is the trust there, because trust is probably the fact that you don't feel vulnerable and you feel you can trust the person you're saying is the most important drivers of creating that thing. It will take time. Finally, I would say organizations that have had some success in moving in this direction, as they start to demonstrate that's a better way of working, that's probably going to be the most convincing argument of all.
Yeah, thank you, Roger. And people who heard me speak about particularly a partnership organisation behaving in a non-bureaucratic, non-hierarchical way, but connecting in a much more matrix, valuing the contribution way. And Lisa Gresti touched on that as well. I don't know, Lisa, if you want to put your microphone on, because Roger started to address that issue of hierarchy, but could you give us a few moments on what you meant by the point you were making?
Yes, thanks, Alan. Hi, Roger. I guess you have largely answered what I put in the chat box there. But again, as an OD practitioner, my first chief exec said to me that I would be in a position to get to speak truth to power, and actually be able to have those honest conversations with him and the chief exec that came after that. And I guess it's how do we get rid of some of that hubris, really, to help people to see the blind spots, and that it's okay whoever points out that blind spot and joins in that conversation. So, you know, is there something really practical we can do at organisational level to allow people to say there's a blind spot here?
So a couple of suggestions. Amy Edmondson has a really nice I think it's 5-question quiz for teams, which can be applied to boards. And I know some people have tried that. It has really prompted conversation. There are other ways, and you've probably tried some of these. I have a colleague who sits at the side of board meetings and draws a line every time somebody speaks to whoever it is they focus their attention on. And when you share those lines back to the board at the end, people are really shocked, because what they show is what we know. Men tend to speak to men. We tend to speak more to men than women. We tend to pay less attention to BME colleagues in the room. And so things like that, I think, that make people think can be quite helpful. I do think, unfortunately, the most effective way is going to be demonstrating that organizations that work in this way are better. So the CQC, for example, has demonstrated that organizations that have better data on race equality provide better care. At some point, that is going to impact more than it has already. And some of this stuff goes all the way down to, I touched on it, the protective hesitancy, the difficulty that individual managers have in conversations. I mean, we all find it sometimes difficult. My children would say I find it very difficult to say things to them that I probably should say or shouldn't say. But particularly where a difference in protected characteristic is combined with a difference in hierarchy. So if you have a white manager with a BME member staff, but it happens with women who are sometimes treated in a very paternalistic way, or with people with disabilities whose abilities are not recognized. We have those kind of eggshell conversations that don't work. So it goes right down to sort of team leaders, frontline team leaders. I think the narrative, using exercises that make people reflect and demonstrating that this is a better way of working, it will take a bit of time, unfortunately. And some of it depends upon, in a way, may depend upon how we end up after COVID, if we get to after COVID, because during COVID, there's been a temptation to move back a bit towards command and control. I understand why that is the case. It's also had fantastic team working. So you've had two things together, people recognizing that matrix ways of working are much more effective, but also organizations very, very conscious of the pressures to deliver and sometimes behaving in quite inappropriate ways. So speaking truth to power, I agree, it's absolutely crucial.
Thanks, Lisa, for that contribution, and Roger. C. Heaney was saying something about earlier on workforce leadership and OD driving progress in this area. Do you want to come on and say a little bit about that?
So, sorry, is that to Steve? Sorry.
No, just waiting for the questioner first to introduce that question.
Thank you.
Hi, Alan. It's Claire. Roger, thank you so much. Absolutely powerful and captivating. It's just, you mentioned there could be exercises or actions, but is there something from a leadership, workforce and OD leadership perspective that we could cascade down? I operate at a place level, and I'm conscious we've got system leaders, all with very different personalities and very different organisations within the system. But are there some golden nuggets that we could be using now? Because you mentioned what gets measured gets done. So if we had a suite of either actions, outcomes, measures that we could harness and actually commit to, then we could start to demonstrate these in practice.
So, well, there are, and in a sense, the metrics that we developed for the Workforce Race Equality Standard, to some degree, have helped to focus attention on some of those issues. I think the Workforce Disability Standard will eventually have the same impact, because the treatment of staff with disabilities in the NHS and elsewhere in public sector is almost as bad. In some respects, it's worse than the treatment that BME colleagues get. Golden nuggets, I think. So having measures is good, and there are some measures that have been developed around inclusion, although there's no agreement on what the best measures are. One thing I would say about inclusion measures is, don't look at the average of an inclusion measure. It's the outliers that tell you what really going on in the organization. It's the people who are outsiders who are excluded. So metrics are important. I do think that the kind of approach that has traditionally been taken, and I understand why HR and OD people have just been drowning in transactional work. They haven't always been able to play the strategic role that they should. But I think it's a good time to change the model. And although I spent a bit of time on it, the evidence is pretty clear. We have to move from responding to individual people concerns and relying on policies, procedures, and training, and moving towards a much more public health approach to workplace culture, where we go out and look for. We have, certainly in the NHS, and I think in local, we have a wealth of data. We don't really use it. We don't triangulate it. You will know instinctively, or if you look at data, which parts of your place are doing better than others in terms of culture. Your kind of set, your knowledge and experience will tell you that. So we need to intervene rather than wait. Use informal lived experience as well as formal data, and look at the sorts of things that work. I mean, the example I used of Google was an extreme one, although I have got one or two trusts thinking about whether they might try that. But the idea that you focus on debiasing processes and look at how you can insert accountability, especially nudges, they are very effective. But people have to be quite brave to use them. There will be some pushback, but I think if HR and OD colleagues think through what's appropriate to your type of organization, might be different in a small specialist trust to in a big acute trust, but applying those, I am very confident they will work. If there was time, I'd give you the example of the men's urinals at Amsterdam Airport, but I won't, because they did the same thing there.
Thank you very much. Appreciate that.
Thanks very much. And Georgina Boone has got an interesting question about anti-racist policies and how they improve safety. Georgina, would you like to come on and just describe that question a little bit?
Yeah, I'm from Somerset NHS Trust, so right down in the south. Yeah, we've discussed a lot recently within our staff networks about the impact of inclusion on safety, and looking at kind of data from the aviation industry, and there seems to be you know, it's kind of the obvious thing that if you've got a better workplace culture, then you'll have better outcomes, and we work in healthcare, so better safety. But I was just wondering if this could be really used as a tool to really get CQC on board and say, look, if we have really clear anti-racist policies, it's having an impact on patient safety. So I just wondered if if you could comment on whether there's been much discussion about that or consideration to that area, please.
She's written about it. In a previous life,
great.
In a previous life, I was the national negotiator for the British Airline Pilots Association. So I became very familiar with the approach in aviation to how you develop safety. Aviation safety is a bit easier than in the health service, because if the plane goes down, the pilot dies. So there's a bit of a kind of vested interest in making it safe. But the principle of having teams where it is safe to raise concerns, where it is safe to admit mistakes, which means teams where bullying is less, and particularly bullying of colleagues who are more outsiders. That means particularly BME colleagues. The evidence is really clear. Where you have less bullying, it's safer. There's some lovely American research demonstrating quite conclusively that levels of bullying are inversely related to the safety of the teams where they work. And given that we know which groups of staff are most likely to experience bullying, LGBT staff, disabled staff, and BME staff, it's a bit of a no-brainer that if you have more attention paid to discrimination, it will make teams safer. There is other stuff, because if staff are treated well, they are going to feel it's safer generally to raise concerns. They're going to pay more attention to innovation. They are not going to disengage in the same way. So yeah, I've written about that, and the evidence I think is pretty clear. And the CQC, there's a CQC report about 3 years ago, which precisely looks at trusts that have better race equality data provide better and safer care. I can send Edna the link to that if that's helpful.
That would be great to just really help push policy and get actual action. Yeah, because I think, like you said, it's something that we know it makes sense, but it's getting that into an action and into a policy. That's brilliant. Thank you so much, Roger.
Thank you.
Thank you for the question, and nice to know that we've gone national at least. So that's great. Edna asked a question about confidence in the employee in the organisation, and I noticed Nigel agrees with it. I wonder if both of you would like to say something about that. Perhaps Edna first and Nigel second.
Oh, thank you. Yeah, so I guess my point is that I, obviously agree with everything you said about the stuff that needs to be done top down and within the organisation, and looking at recruitment. But one of the things that I feel, and when I speak to maybe some colleagues from BAME backgrounds, is that actually it's that not having the confidence to even think that they could strive for more or take that next step up because of, maybe structural racism or bullying, or what some of the things that you've mentioned have happened to them. So it's kind of, it's worn away at their confidence. So there is something about, or how do we try and address that? Because actually we need to be able to build BAME people up as well, to have that confidence to actually, take that step forward.
And Nigel?
Sorry, I was just trying to unmute. Yeah, so I agree with what Edna said, and I must admit my own experience comes a blend of working in practice, so working with the Big Four, and then working in the NHS. And there's something for me quite it's quite kind of germane, quite generic about when you're beginning to speak, that you almost have to overcome certain views or doubts even before you start speaking. I think there is a tendency of some kind of minority groups or people who consider themselves outsiders to be more receptive and more aware of what the climate in the room is like and what the element of doubt is. And that could kind of be feeding their own confidence to be able to kind of press a point or to explain. So I think there's something about, it's a two-way thing for me. It's about the person, but it's also they're almost like confounders. The temperature in the room needs to be changed to give that person the confidence to be able to perform as that person needs to.
So
Thank you, Edna and Nigel.
If I take those two questions together, Alan?
Yeah, by all means.
So they're both really important questions, and they're rooted in reality, because Black and minority ethnic staff, really from the time that they are born, are likely to receive less good healthcare, face greater challenges in education, be subjected to all sorts of stereotypes. You see it in the justice system and so on. And the cumulative effect of, I can't remember, one of the colleagues referred to it as microaggressions. The cumulative effect is to make you quite anxious about what you're going to do and how you're going to be received. I mean, there's, and you can see how that applies in something goes wrong. People may be more likely to be defensive. You can see it in recruitment. There's a raft of research. So Shelley Carell, for example, showed that women and BME candidates were more likely than male and white candidates to find that one weakness was generalized into an overall negative rating. You've got a whole where BME and white candidates, particularly BME candidates, were seen, but if they said what they had done, there was often an assumption that somehow or other what they'd achieved was less due to their own ability and more due to other people in their team rather than the effort that they made. And people know this happens, and people know that people have stereotypes. And I think it's really hard for us, as I'm white, it's really hard for me to always understand the pressures that people feel under, the nervousness about walking into situations. That's the problem. I think there's a greater understanding of that. I think challenging it and changing it is that there's stuff that can be done at the individual level, giving staff encouragement, giving them space, leveling the playing field. Remembering when people, sometimes people say, why are we doing all this positive action? I say, because for thousands of years, people like me have had positive discrimination, which is why I have ended up in a relatively privileged position, despite my working class origins. I'm a white bloke. And other people haven't. So we have to level the playing field, but we have to make it safe for people to think, actually, I'm going to go for that job. We have to give BME people the tap on the shoulder to say, why don't you go for this job? I will help you prepare for it in the way that we know happens often with other people. So I'll stop there for reasons of time, but there's lots of things we can do. And there are some trusts, you can see it in their results, where there's a lot more BME people in more senior positions. And it's because they set about to make that difference by starting to acknowledge the starting place for many BME colleagues in the NHS and indeed in other locations.
Thank you very much indeed, Roger, and thank you for everybody that's attended this session, but particularly participated and had the opportunity to ask a question. I said at the outset we were hoping that this webinar and question and answer session will be the start of a conversation. We're very determined to make more progress and to accelerate progress in this area as the partnership. And Roger, you give it as a fantastic stimulus there to aid our debate and inform our conversations. So thank you very much indeed. It's been absolutely splendid. And I'm sure we'll get, as we did our previous session, demands for the video and so on. So we will publish you with your permission and do that. Thanks very much, everybody. There's no good way to say goodbye other than goodbye. That's been a fantastic session. Thank you for your participation. All the very best.